Gestational diabetes. There are two main categories of diabetes mellitus encountered during pregnancy: pre-existing diabetes mellitus and gestational diabetes mellitus. Let us go through the various complications and management of each of these types. Pre-existing diabetes. Pre-existing diabetes mellitus refers to diabetes that is already present in the woman prior to pregnancy. It causes complications for both the mother and her fetus. Effects of diabetes on pregnancy. A pregnancy complicated by pre-existing diabetes carries an increased risk of preeclampsia, infections such as urinary tract infections, pyelonephritis, and vulvovaginal candidiasis. She is also more likely to require an assisted vaginal delivery with vacuum or forceps or undergo a cesarean section. Effects of pregnancy on diabetes. The mother's diabetic condition may also be worsened by the ongoing pregnancy. There is an increased risk of progression of diabetic retinopathy, worsening proteinuria and edema, and deterioration of pre-existing diabetic nephropathy. During pregnancy, the body's ability to maintain normal glycemic control is challenged by the antagonistic effects of circulating placental hormones, which include human placental lactogen and cortisol. Decreased insulin sensitivity can lead to severe complications such as an increased risk of diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. Additionally, there is a paradoxical predisposition to hypoglycemia as a result of hypoglycemia unawareness from autonomic neuropathy, nerve damage, reduced food intake during hyperemesis episodes, and iatrogenic tight glucose control. Effects of hyperglycemia. The fetus of a diabetic mother is affected by hyperglycemia due to high concentrations of serum glucose being transported across the placenta into the fetal circulation. This leads to both short-term and long-term complications in the fetus's development from the first trimester and beyond. In the first trimester, there is an increased risk of miscarriage and congenital abnormalities, especially of the cardiovascular system. In the second and third trimester, there is an increased risk of accelerated fetal growth and macrosomia, big baby. Fetal hyperglycemia, due to transplacental passage of maternal glucose, stimulates the production of insulin by the fetal pancreas. This is known as secondary fetal hyperinsulinemia, which has several effects on the fetus. The first is the promotion of fat disposition, as insulin is an anabolic hormone, resulting in a large for gestational age fetus. Hyperinsulinemia also delays fetal lung maturation by inhibiting the production of surfactant by alveolar cells, increasing risk of respiratory distress syndrome at birth. In addition, as pre-existing diabetes mellitus is a vasculopathic condition, there is an increased risk of chronic fetal hypoxia from placental insufficiency. This may result in sudden unexplained intrauterine death or stillbirths. Fetal macrosomia increases the risk of shoulder dystocia, birth trauma, and asphyxia at delivery. Fetal hyperinsulinemia predisposes to neonatal hypoglycemia and promotes antepartum extramedullary hematopoiesis. Polycythemia, in turn, increases the risk of neonatal jaundice. Intrauterine exposure to hyperglycemia may predispose the unborn fetus to cardiometabolic syndrome and type 2 diabetes mellitus later in life by way of metabolic programming. This is known as Barker's hypothesis. Management of pre-existing diabetes. A multidisciplinary approach is required to manage pre-existing diabetes in pregnancy. All women with diabetes who are thinking about pregnancy should be referred to high-risk pregnancy clinics for preconception counseling. Improved glycemic control can be achieved with increased frequency of home blood glucose monitoring. Lower HbA1c levels improve perinatal outcomes and reduce risks. The recommended HbA1c should be less than 6.1% at the time of conception. Women with pre-existing diabetes are recommended to consume a higher dose of periconception folic acid, 5 mg per day, for the prevention of neural tube defects. Those on oral hypoglycemic agents should be switched to metformin or insulin to achieve glycemic control. Use of angiotensin-converting enzyme inhibitors, ACE-I, and angiotensin receptor blockers, ARBs, to manage microalbuminuria is contraindicated in pregnancy. These medications should also be stopped and switched to suitable alternatives. As risks of diabetic micro and macrovascular complications may be exacerbated by pregnancy, all women with pre-existing diabetes should have baseline fundal photography at booking to assess for diabetic retinopathy. This may need to be repeated in the course of the pregnancy depending on the results of the first assessment. Baseline assessment of renal function to measure serum urea and creatinine and degree of proteinuria. Referral to a nephrologist is recommended if serum creatinine is more than 120 micrograms per liter or proteinuria is more than 2 grams per day. Baseline assessment of diabetic autonomic neuropathy. Women with type 2 diabetes are more likely to harbor features of metabolic syndrome such as obesity and hypertension. Obesity in particular can lead to further complications throughout the pregnancy. Weight reduction and optimization of body mass index in obese women prior to pregnancy would reduce risks of these complications. Antepartum management. In the first trimester, all pregnant women with diabetes should receive a dating scan to assess the viability of the pregnancy and obtain an accurate gestational age and estimated date of delivery, EDD. This is critical as important decisions regarding the timing for induction of labor are based on the knowledge of the EDD. From 12 weeks gestation, those with pre-existing diabetes should be advised to take daily low-dose aspirin to reduce risk of developing preeclampsia. Between 18 to 20 weeks gestation, women will undergo an early fetal anomaly scan to assess for major congenital abnormalities, particularly of the cardiovascular system. This is repeated between 21 to 24 weeks gestation. At the end of the second trimester and every 4 weeks thereafter, women with pre-existing diabetes are recommended to undergo serial assessment of fetal growth and liquor volume. Macrosomia and polyhydramnios are common in diabetic pregnancies and should be managed. However, growth restriction in a diabetic pregnancy is indicative of uteroplacental insufficiency with risk of in utero fetal demise. It implicates the development of preeclampsia, hyperglycemia-induced toxic placental senescence, diabetic macrovascular disease of the placenta, or a combination of these factors. Excess maternal glucose is preferentially transferred across the placenta rather than peripherally metabolized. Glycemic control in pregnancy must be tightly controlled to achieve glucose levels of less than 5.5 millimolar per liter pre-meal, less than 6.6 millimolar per liter post-meal. Women with diabetes should record 7-point blood glucose profile pre- and post-meals and once before bedtime for at least 2 days of the week throughout the antenatal period. They should be monitored closely throughout pregnancy at 1 to 2 week intervals, with those on insulin requiring even more frequent monitoring as titration of insulin doses is made based on home blood glucose profile. Insulin requirements increases as pregnancy advances, and it is important to recognize and remediate hypoglycemia symptoms. Diabetic patients require blood pressure and urinalysis assessments at every antenatal visit to monitor for preeclampsia. Preeclampsia is diagnosed as any woman with new-onset hypertension of more than 140 over 90 millimeters Hg with proteinuria 2+ or greater beyond 20 weeks gestation. As the rate of late stillbirth is approximately 4 times higher in women with diabetes, it is recommended that labor is induced around 38 to 39 weeks of gestation, especially for those on insulin. Diabetic pregnancies are not contraindicated for a trial of vaginal delivery, and cesarean section should be reserved for usual obstetric indications. However, women with macrosomic fetuses are offered the option of a cesarean section, as it is not possible to predict the risks of shoulder dystocia. Counseling by the obstetrician is essential to allow the woman to understand the pros and cons of the options available to her. Intrapartum management. The goal of insulin therapy during labor is strict glucose control, regardless of whether the woman is induced or arrives in spontaneous labor. Once in active labor, a sliding scale of intravenous short-acting insulin infusion and dextrose, 5% or 10%, is commenced. The capillary blood glucose is checked hourly and the insulin infusion rate altered according to sliding scale and the individual daily insulin requirements. The target glucose level during labor and delivery is between 4 to 7 millimolar per liter. Insulin drives extracellular potassium into the cells. It is important to monitor and replace potassium in the intravenous dextrose to avoid hypokalemia. Postpartum management. Insulin requirements fall to pre-pregnancy levels with delivery of the placenta. Recall that it is the placental hormones that instigate insulin resistance in pregnancy. Resume insulin for women with pre-existing diabetes at 50% of the pre-pregnant dose once normal diet is accepted or tolerated. The dose can be titrated over the following weeks until optimal. Breastfeeding is not affected by insulin or metformin. Gestational diabetes. Gestational diabetes mellitus, GDM, refers to diabetes diagnosed in the second or third trimester that is clearly not pre-existing. Singapore has one of the highest GDM rates, affecting 1 in 5 pregnancies. Contributing factors include obesity and advanced maternal age, further exacerbated by changes in maternal carbohydrate metabolism, decreased insulin sensitivity, and increased insulin resistance driven by hormones during pregnancy. Diagnosis and screening. GDM is diagnosed by performing a 75-gram oral glucose tolerance test, OGTT, between 24 to 28 weeks of pregnancy, the period coinciding with increase in gestational insulin resistance. HbA1c should be avoided for both screening and diagnosis of GDM. Additionally, HbA1c values are generally lower during pregnancy as a result of increased red cell turnover. Women not known to have pre-existing diabetes but with high risk factors for diabetes should undergo screening for pre-existing diabetes as early as possible in pregnancy to allow appropriate management of possible complications. In Singapore, universal screening is recommended because Asians have a higher prevalence of GDM. Universal screening is also associated with improved maternal and fetal outcomes. Management. Management of GDM is similar to that of pre-existing diabetes mellitus. The aim is to achieve optimal glycemic control in pregnancy, and the mainstay of treatment is dietary modification with the help of a dietitian and appropriate regular exercise. 7-point blood sugar profile monitoring should be performed throughout the antenatal period. If pre- and postprandial targets cannot be achieved by diet control, insulin will be commenced. If it is the postprandial readings that are persistently elevated, the patient will be prescribed fast-acting insulin analogues to be taken before meals. If there is fasting hyperglycemia, then intermediate-acting insulin will be required at bedtime and or before breakfast. Obstetric management. Like pre-existing diabetes, GDM is associated with increased risk of preeclampsia and higher incidence of macrosomia. However, it is not associated with fetal congenital abnormalities. Women with GDM should have regular checks of blood pressure and urinalysis and regular fetal growth scan to assess time and mode of delivery and better intrapartum management. Elective birth by induction of labor or cesarean section at 40 to 41 weeks, if indicated, is offered to women with uncomplicated, well-controlled GDM on diet modification alone. Induction of labor at 38 to 39 weeks gestation should be considered for women with GDM on insulin or with poor glycemic control. Intrapartum management. The target blood glucose levels intrapartum is the same as pre-existing diabetes at 4 to 7 millimolar per liter. Majority of women with GDM do not require insulin. Those on large doses of insulin are managed with insulin sliding scale. Insulin treatment is discontinued following delivery. Postnatal management. Plasma glucose levels revert to pre-pregnancy levels 6 weeks after delivery. It is recommended to have a 2.75 gram OGTT performed between 6 to 12 weeks after delivery to reassess glycemic status using non-pregnancy thresholds. For women with GDM, there is a 7-fold increased risk of developing type 2 diabetes. In Singapore, an estimated 4 in 10 women with GDM develop pre-diabetes or diabetes in the 5 years following delivery. Sustained lifestyle modifications reduces risk of that progression by 35% over 10 years. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.